name is Guy Eakin. I'm the Chief Scientific and Medical Officer for the National Psoriasis Foundation. I want to thank everybody involved today, including all of our participants who are coming to join us in a conversation about mental health and psoriatic disease. So we had, looks like we have about 30 people on the call who have agreed with the National Psoriasis Foundation that treating psoriatic disease requires a consideration of the many ways in which psoriatic disease intersects with the patient's life. So today, as you all know, we're focused on mental health, how it is challenging to our patients, how it is treated, and then also the important steps of how the medical community can harmonize the needs of the patient, of that single patient in your office, with the evidentiary basis of care. So there couldn't be a better person to guide us through this conversation than our host, Dr. Vanessa Cutler, who's a psychiatrist at the NYU Grossman School of Medicine. And she has been an incredible partner to the NPF in the past, providing guidance on this topics through webinars, CDC-supported podcasts, and other print materials that I'd like to make you aware of and hope that you'll take advantage of. But without further ado, this is not my talk. This is Dr. Cutler, so I'd like to turn the mic over to her and let you get on with the presentation. Thank you so much.
So I am a dual board certified adult and child psychiatrist. I practice in New York. And I would like to extend a thank you, of course, to the National Psoriasis Foundation for having me host this webinar. I think this is a really important topic and one that's becoming increasingly more relevant given the stressors we have all been through recently. So without further ado, we can go ahead and start the show. So this is entitled Mental Health and Psoriatic Disease. We can head to the next slide. These are my disclosures. I do sit on a psychodermatology advisory board for CERAB. So starting here with a note on embryology, because I think that this is very important to keep in mind when we talk about this topic, because oftentimes people are like, mental health, skin, how does this make sense? So we have to bring it way back to the basic science, which is embryology and how we develop as humans. So essentially during week 3 of development, the blastula, which is that little group of cells, undergoes gastrulation. And then we become gastrulas, and that's going to be an ectoderm, a mesoderm, and an endoderm. And then all of a sudden, what we start to see happen is further development with a notochord signaling the overlying ectoderm at the neural plate to form the neural tube and the neural crest. The neural tube portion of the developing gastrula then becomes the central nervous system, and the neural crest becomes the peripheral nervous system, melanocytes, and facial cartilage. And the remaining ectoderm becomes epidermis, hair, exocrine glands, and the anterior pituitary. And much of this process is really controlled by FGF, which is fibroblast growth factors that act upon a particular group of proteins to determine which cells become non-neural cells here. So we can't really talk about this topic, again, without having a little basic science primer on embryology. As you can see here, we have a nice little illustration of the ectoderm. We have our epidermis, then we also have brain neurons, and then we also have the melanocytes, which are our pigment cells. So we can go to our next slide. So here is the role of stress in chronic illness. So psoriasis, chronic illness. There are many chronic illnesses where we see significant psychiatric comorbidity, typically with an affective or an anxiety disorder. So depression is common in about 50% of patients with a chronic illness versus 8% of the general population. Activation of the HPA axis, which is kind of what connects our adrenal glands to our brains, and then blasts out hormones is the most likely mechanism that underlies chronic illness with psychiatric comorbidity. Increased CRH, so that is a releasing hormone, and subsequent glucocorticoid receptor resistance then leads to an upregulation in inflammatory cytokines and persistence of inflammation. And then this kind of never-ending storm of cytokine production activates our brain microglia, which we think potentially could lead to psychiatric issues, especially in conditions where we know that inflammation plays a very large role in the pathophysiology of the illness. Activation of the HPA axis then of course results in cortisol release, which is a major stress hormone, activation of our sympathetic nervous systems, and then the epinephrine and norepinephrine release. So it's kind of this very complicated and perfect storm of inflammation, stress hormones, and the nervous system. So we can move to the next slide. So what is psychodermatology? So is this a real thing? Yes, it is a real thing. It's also known as psychocutaneous disease or psychoneurocutaneous disease as well. We do have a society, and basically psychodermatology is a condition that involves interaction between the mind and the skin. So this comes from AFP. And really, we're looking at conditions where management involves evaluation of skin manifestations, as well as the social, familial, and occupational issues underlying the issue. Because again, as we know with psoriasis, psoriasis does not exist independently of the person who is wearing the psoriasis. So you can see down here, we have a nice little diagram of how dermatology and psychiatry intersect in this particular topic of psychodermatology. So we can head to our next slide. So there is this evolving idea of the NICE network. So this is the neuroimmunocutaneous endocrine network, which is definitely a mouthful. So what we mean when we say the NICE network is that the skin itself is providing bidirectional communication between the immune and nervous systems, which involves inflammatory mediators that cross the blood-brain barrier, as well as other cutaneous neuropeptide messengers. So in psoriasis in particular, BDNF and mitogen activated protein kinase pathways comprise a shared mechanism between psoriasis and anxiety and depression in animal models. And then in psoriasis patients with depression, we do tend to see very high serum concentrations of IL-6, 18, and 17A, which we believe likely leads to a shared inflammatory mechanism. So, organization of clinical concepts in psychodermatology, now that we've moved away a little bit from some of the basic science. So really how we kind of conceptualize this is the psychophysiological, primary psychiatric, and secondary psychiatric. So this is a very nice chart here. So psychophysiological, these are skin problems that react to emotional states. So psoriasis. Primary psychiatric, these are self-induced cutaneous manifestations. So this is an excoriation disorder. This is trichotillomania. Things that really tend to be driven by primary psychiatric illness. And then our secondary psychiatric is really related to disfiguring skin conditions. This is the, I don't want to go out because I have a horrible flare on a visible part of my body or in other illnesses. I have terrible acne eruption right now on my face. I don't want to go outside. I feel badly about myself. I'm isolating and I'm withdrawing. And that's what we would consider to be more along the lines of secondary psychiatric concerns here. So we kind of can see some of the other conditions related to psychophysiological, alopecia, areata, sebderm, and then of course some more of the primary psychiatric disorders, which typically also will present to a dermatology office first. And we're going to see trichotillomania, excoriation, delusional parasitosis, and then of course secondary psychiatric disorders where we see a tremendous amount of psychiatric morbidity, which is vitiligo, acne, psoriasis, alopecia, of course, and many more. So we can move on. So again, like we talked about before, psoriasis as a psychophysiologic disorder. In well-managed psoriasis, the issue of stress might be less important, but in treatment recalcitrant cases, psychological or psychosocial factors do start to become increasingly more relevant. And then looking at psoriasis as a secondary psychiatric disorder, psoriasis is visible, can lead to feelings of disfigurement, especially depending on where the flare is. There is social impairment if the condition is perceived to be contagious. And, we have actually seen this in studies where they have surveyed medical students about people with visible skin conditions. And occupational impairment, it's much harder to become employed in roles where appearance is important. And there are a lot of occupational roles where appearance is important. So these are, just a couple of examples of how psoriasis is not only a psychophysiological disorder, but also secondary psychiatric disorder as well. Okay, so we can't really talk about psoriasis without talking about the itch-scratch cycle. So itch is one of the most common dermatologic complaints, and it is very hard to manage. Oftentimes people will present, they say have an itch, and it's back and forth and back and forth and back and forth. The itch is a pain-like sensation with a reflex-like response. There are a couple of causes of itch. So, we see itch as a pruritoreceptive within that category. We see it as neurogenic, and that's itch that originates from an organ other than skin. So that would be something like hepatobiliary disease. We see itch as neuropathic. So that's typically due to damaged central or peripheral afferent nerves. So an example of that would be, some kind of post-herpetic flare. And then of course, psychogenic itch, which is likely also due to stimulation of afferent itch fibers due to central pruritogens. So that would be something like elevation of substance P that then leads to a psychogenic itch. And then the latter part of the cycle, which is scratching. What does scratching do? Relieves the itch by causing localized pain, provides pleasure or reward via the limbic system, which is the part of our brain where we experience emotion, and is potentially also affected by localized serotonin release actually in the skin. But scratch also disrupts the epidermal barrier and leads to increasing inflammation. So what is psoriasis? Psoriasis is a chronic autoimmune genetic inflammatory disease, and it's not just skin deep, as we all know here. It can affect multiple extracutaneous organ systems. There are multiple comorbid conditions now that we're coming to associate with psoriasis, including CKD, cardiometabolic conditions, psoriatic arthritis, of course. The hazard ratio for any psychiatric disorder, if you have psoriasis, is 1.75. And then, of course, in pediatric populations, there is a substantially greater risk for depression and a tenfold greater risk for anxiety. Both patients and their partners can suffer due to disease severity. We think it tends to affect about 125 million people worldwide. and occurs equally in males and females with an average age of onset in young adulthood, higher prevalence in high-income countries and white people. So we can go to our next slide. So here are just a couple of examples of how psoriasis can present. Of course, in A, B, and C, we're seeing psoriasis vulgaris. So this is plaque psoriasis, most common type. E is erythrodermic, which of course can be potentially life-threatening. We've got an example of pustular, palmar-plantar, inverse, which can also be very confusing to non-derm people. Nail psoriasis, of course, which doubles one's risk of psoriatic arthritis. And then in picture J, we have a picture here of psoriatic arthritis, and we can see deviation of the joints. So pathophysiology of psoriasis, much better understood than pathophysiology of other skin diseases. So this is a heritable disease. We can explain about 30% of disease heritability through genetic loci. HLA-C 6.2 is the major risk genetic factor for early onset disease. The variant of ERAP1, which codes for aminopeptidase, also markedly increases one's risk of developing psoriasis. Typically, psoriasis needs some kind of environmental trigger, so it does not manifest unless there is some kind of environmental trigger like stress, infection, weight gain, or obesity have been implicated as triggers, and then drugs and alcohol use. And then, of course, IL-23 and Th17 play a key role where we're seeing kind of the interface here of our immune systems. So coming into the psychiatric comorbidity of psoriasis, looking at depression and suicide. So it's no secret that psoriasis does have a very high association with depressive symptoms. Risk factors do include being female, having a younger age of disease onset, as we saw a couple of slides back. Also having lesions in visible areas also tends to predispose one to experiencing depressive symptoms. About 20 to 30% of patients with psoriasis do experience depression, so it's a pretty significant portion. And again, there is a bi-directional relationship. So major depressive disorder is a risk factor for the development of psoriasis, particularly in males. The literature is a little unclear on whether or not an increased risk of suicide exists. There is some literature that supports the increased risk of suicide and some that does not. A lot of psoriasis guidelines don't actually discuss depression screening, and as we all know, given the limited amount of time sometimes that people have in appointments to see patients, depression screening doesn't always get done. And then untreated depression itself may hinder treatment of psoriasis. So here we are moving to the psychiatric comorbidity of psoriasis, looking at anxiety and stress. So prevalence of anxiety disorders in people with psoriasis is about 3 times higher. Treatment of psoriasis is associated with a decline in anxiety. Stress plays a role in the development of psoriasis, but the mechanism of how stress plays a role is not well defined. And again, this is another example where we might see a bidirectional relationship. Over 30% of patients with psoriasis do believe that stress plays a role in their flares. And people who have schizophrenia also are at higher risk for developing psoriasis. Okay, so additional concerns here, stigma and relationships. Stigma is a very big topic, of course, in psoriasis. Predictors of stigma include bleeding, younger age at onset, employment status, duration of disease, and also rejection experience that is perceived to be due to psoriasis. Not unsurprisingly, severe family dysfunction is much more common in patients with psoriasis. We do tend to see this a lot in other skin diseases. I think of atopic dermatitis being one of them, particularly with younger kids. There is an inverse relationship here between disease severity and income, and then rates of excess alcohol consumption can be very high in these patients. So, screening for psychiatric symptoms, typically not done in a derm visit because there's so many other things that need to be covered. Focus really is on treating the skin in the dermatologist's office. There's not enough time in the visit to focus on other comorbidities. Stigma, of course, remains a huge barrier in terms of screening. The other thing too is that, oftentimes the questions that are asked for depression screening are somewhat different, a little more personal somehow than questions asked to screen for other conditions in medicine. And interestingly, patients typically will rank embarrassment over their appearance as their top concern on any kind of quality of life survey, while dermatologists tend to rank it the lowest feature because their concern is really just controlling the severity of the disease. So this is an interesting group of patients. So patients who have longer disease duration. Lower levels of distress have actually been reported in patients with longer disease duration. It does seem that there is a cumulative impact of living with psoriasis, which may be due to maladaptive coping schemas or avoidance. One study did demonstrate a reduced signal response on MRI to disgusted faces by people with psoriasis, which suggests a coping strategy to avoid distress when encountering a disgusted face. So that would be almost a learned maladaptive coping strategy. Oh, next slide. Okay. So moving into some of the screeners that are used clinically to screen for psychiatric symptoms. And again, this is predominantly looking at disability, morbidity of symptoms. So the Woolley questions, this is a 2-question test. It's very similar to the PHQ-2, but is a much more sensitive screening. The 2 questions are, have you frequently felt dejected, sad, glum, or hopeless during the past month? And have you taken significantly less pleasure and joy in things which you otherwise enjoy doing over the past month? So this, is an easy questionnaire to utilize in a clinic setting. We can go to our next slide. Moving on to another battery that can be used. So this is the Psoriasis Quality of Life 12. So this is a 12-item self-administered battery. Doesn't really seem to show a correlation with the PASI score. And data using this particular screener suggests that limited psoriasis on a visible area may affect quality of life more than a PASI might suggest. The PDI is a psoriasis disability index. This is a 15-question self-administered assessment, has very good internal validity, been used in multiple studies and settings, translated in multiple languages, does seem to correlate with a PASI score across numerous studies, with observations that higher PDI is associated with a higher PASI score. So this is the Psoriasis Area and Severity Index. So this is, really what tends to be used clinically by, most dermatologists or most dermatology settings, and should be to kind of track illness and initiate treatment. So this is the Psoriasis Area and Severity Index ranges from 0 to 72, with a score over 10 being considered severe. Scores over 40 are considered rare. The score severity is based upon the intensity of redness, thickness, and scaling, and then kind of how that manifests over percentages of body area. This can be a way to monitor progression and evaluate effectiveness of treatment. Really, the goal of treatment is thought to be a reduction in baseline symptoms of 75% or greater. There is some association between improvement in the area and severity index and improvement in quality of life scores. And one of the major limitations is that this is a subjective assessment that's being done by the dermatologist. So evaluation can differ based on subjective evaluation. The DLQI, so this is the Dermatology Life Quality Index, which also is something that is often used in kind of screening patients with psoriasis or any other skin disease. So this is a self-reported questionnaire scoring from 0 to 30 that measures 6 quality of life subscales. So this is symptoms and feelings, daily activities, leisure, work and school, personal relationships and treatment. Can be completed in 1 to 2 minutes. One of the limitations, of course, is that it might underestimate the severity of disease. So, PASI 9 does not necessarily mean a corresponding drop in DLQI score. And the relationship between DLQI and the severity index is not really as cut and dry as one might think. The DLQI provides qualitatively different data about how a patient is doing through correlation percentage change. In DLQI and PASI scores may be related. So that is kind of where we see this relationship occurring, but it's not exactly a direct linear relationship. Interestingly, in this Japanese study that was done fairly recently in 2021, amongst patients starting biologics, those with DLQI scores that were greater than or equal to 6, which is kind of one of the major cutoffs here between less morbidity and moderate morbidity, these people had a higher median PASI score, higher itch, higher GAD-7 scores, higher skin pain scores, leading to the conclusion that the DLQI is probably picking up on morbidity that the PASI itself does not capture. And then we come to some of these screeners that we see very frequently used in primary care settings. Sometimes they're used in psychiatry settings. So this is the GAD-7, the PHQ-9, and the PHQ-2. So the PHQ-9, which is the Patient Health Questionnaire 9, because it has 9 questions, can be useful for assessing severity of depression in patients with psoriasis, and it has a sensitivity and a specificity of 88%. So it's fairly reliable. PHQ-2 is actually just the first 2 questions of the PHQ-9 and is only really a screener for depression, and it seems to have kind of variable sensitivity depending on what you look at. The GAD-7 is a self-reporting questionnaire that assesses for generalized anxiety disorder that has a sensitivity of 92% and a specificity of 76%. It's a 7-question questionnaire. So if you were suspicious that maybe one of your patients with psoriasis had a level of anxiety that seemed maybe a little bit outside of the norm of a stressor, that would be, I think, something that you could utilize in clinic settings. So just some additional disease-specific batteries. They do tend to come up quite a bit in the literature. You may see them, if you're reading about, concepts of quality of life issues in psoriasis. So the PLSI, which is the Psoriasis Life Stress Inventory. There's the Psoriasis Index of Quality of Life. There's the Feeling of Stigmatization of Psoriasis. There's the Dermatology Quality of Life Scale. which is not necessarily specific to psoriasis. There's the Skindex, which also is not necessarily specific to psoriasis, and then the SPI, which is specific to psoriasis. So making the referral, barriers to obtaining mental health care. Oftentimes when patients go to a dermatologist, go to primary care, they are not expecting to leave, with a diagnosis of depression or a diagnosis of anxiety. And the question then becomes, when this is brought up in a clinic setting, is why would I ever need to go and see a psychiatrist? I thought I was here for my psoriasis. So patients frequently resist referral to a mental health care professional. Lack of screening and stigma are probably both barriers that do realistically exist. The other barrier, of course, is a lack of mental health professionals. There's a very finite number of people who can treat patients, and an even smaller number of people who maybe understand the relationship between psoriasis and mental health concerns. If a patient has an inability to travel due to disability or morbidity, that may also be a barrier to obtaining additional mental health care services. Although, with a lot of mental health care services transitioning to remote, I think there is, still a way for those patients to access. And then, just frankly, the lack of accessibility, the expense, and the wait. So a couple of treatment strategies. So we have here the ABC model of intervention. So A is taking a look at affective regulation. And that is something that we can use medication to treat sometimes. We can use psychotherapy to treat. B is looking at the component here of behavioral addiction. And I think that becomes very relevant when we look at something like the itch-scratch cycle. So that is, learning techniques to maybe substitute habits that are maladaptive coping skills that may be getting in the way of care, that may be getting in the way of reducing disease severity, and then cognitive control, which truly is habit change. So the role of biologics is a pretty important one when we look at kind of this topic of depression and psoriasis. So the TNF alpha antagonists, so there are 3 right now that are approved for psoriasis, can improve both physical symptoms as well as fatigue and sleepiness by reducing some of these cytokines that tend to reach the CNS. So that's 6, 10, 12, 13, and 17. There's actually a very good paper that recently came out of Romania that was looking at the use of biologics in biologics naive patients with psoriasis versus healthy controls, where we see a significant decrease in the PHQ-9, the GAD-7, the severity index, and the DLQI at the 6-month mark. No biologic agent in that study was considered superior, and an increased severity index or an improved severity index correlated significantly with lower depression and anxiety scores. However, decreased DLQI did not, which I think, is just another example of how the relationships between these indexes are not as cut and dry as one might think. While not statistically significant in this Romanian study, guselkumab was associated with the highest difference. And then, in a couple of other studies too, we're seeing some of these other biologics that have demonstrated an association with a decrease in depression and anxiety symptoms versus placebo. And the ones that seem to target IL-17 and IL-23 might actually be superior in decreasing depressive and anxiety symptoms. But I think that this is an evolving area of study. So role for psychotropics. kind of surprisingly not well studied, with a lot of very small data sets kind of being employed in a lot of these studies. I was surprised again because, the comorbidity of depression in psoriasis is 20 to 30%. So there was a small study that was looking at patients with moderate or severe psoriasis and depression who were treated with a TNF alpha agonist, that compared treatment with escitalopram, which we know is Lexapro, and psychotherapy versus psychotherapy alone, where we saw superior results, and an improvement in actual symptoms in the escitalopram group. There was a very large population cohort study out of Taiwan, that was, that was looking at a large national database of patients, who found that patients with MDD who were using antidepressants actually had a lower risk of developing psoriasis than non-users, and that most types and dosages seem to protect against psoriasis in patients with MDD, particularly SSRIs. So one of the explanations, of course, is that SSRIs do tend to exert an anti-inflammatory effect. We saw this in COVID with fluoxetine. We see this in ischemic stroke. We see this in MI, where the comorbidity of depression can be quite high in a lot of these other illnesses, and treatment with an SSRI likely improves mood, but also likely is exerting some kind of anti-inflammatory effect. So we do have data that does show that SSRI use results in decreased numbers of inflammatory cytokines in patients with anxiety and PTSD. Now, one of the other things, of course, to note with psychotropic use is that there are, a number of case reports where we do see concern for exacerbation of a flare secondary to lithium, Prozac, Wellbutrin, olanzapine, quetiapine, Abilify, and funnily enough, escitalopram too. So I think that, again, you can't just put a patient with psoriasis on one of these medications and, check out for 6 months. These are patients who need really good, really close follow-up to make sure that not only is the psychotropic effective in treating the psychiatric comorbidity, but also to ensure too that we're not causing an uptick in the number of flares. So looking at behavioral and psychological interventions, really what the data shows here is that CBT-based interventions are the most effective interventions for patients with psoriasis and comorbid depression or anxiety. Interestingly, and this was, a paper that was done in 2019 that I looked at, so it was pre-COVID, but in-person intervention was found to be more effective than remote. I don't think that that has been studied now or recently since 2020. Psychological interventions do seem to be more effective in patients with moderate to severe psoriasis, and interventions that focus on a single strategy like health education or treatment compliance improvement or some kind of supportive therapy approach don't seem to have the same kind of efficacy as CBT-based interventions have. Oh, next slide. Okay. So CBT, cognitive behavioral therapy, good data for support. The trials are small. We're looking typically at ends that are much less than 100 patients. So in one particular study, we saw 40 patients receiving adjunctive CBT demonstrate a significant reduction in their scores at 6 weeks and 6 months, with actually 64% achieving over 75% clearance in their symptoms, as well as reductions in anxiety and depression. There is some thought too that CBT can reduce stigma and confusion surrounding affective and anxiety responses to the disease. and that CBT may improve severity by inhibiting inflammation. CBT might also help patients obtain a level of autonomy over their illness and make them more participative in care, particularly once a mindset or loss of control has happened. And we do see that happen from time to time, of course, in patients who do have a chronic illness diagnosis. Habit reversal training. So this is something that we employ quite a bit in excoriation disorders and trichotillomania. So this can be useful in breaking the itch scratch cycle. So really, HRT, habit reversal training, is actually something that can be done in the office kind of over the course of a number of appointments. So this is becoming aware of the habit and identifying the trigger, because oftentimes the itch is not something that is consciously recognized by the patient. Stopping the habit and then substituting with a new habit. So an ideal substituted habit, of course, makes the old behavior impossible to carry out. So that would be something, for someone who's a very bad scratcher, to squeeze your fist. Oftentimes too, for patients, what I'll recommend is some kind of slime that has a plastic junk kind of in it, little stars, hearts, lightning bolts, whatever, because that feeling of scraping the slime off of the plastic junk can be very satisfying and very similar to the sensation, I think, that is experienced when people do pick or scratch. And then again, as I said, you can modify this to an in-office intervention over the course of several visits, which has been carried out before. Hypnosis. Hypnosis always seems to make an appearance anytime we talk about any kind of psychiatric comorbidity or dependency, substance dependency. We see it pops up all the time with tobacco use. So for patients with psoriasis, very poor data for use, which is not a surprise. Really no significant difference found in severity index score between intervention and control groups. However, highly hypnotizable patients did demonstrate a greater percentage reduction in the severity index score than moderately hypnotizable patients. So take that for what it is. And then arousal reduction and mindfulness. Everyone's always talking about mindfulness, mindfulness, mindfulness. So mindfulness, meditation-based stress reduction, this can be something that is helpful. So in patients who used a meditation-based stress reduction audio tape as an adjunct to phototherapy, did show significant improvement in the rate of psoriasis clearance compared to phototherapy alone. And another study looking at 20 weeks of meditation, which is a lot of meditation, showed significant improvement in psoriasis severity through guided imagery exercises, or though guided imagery exercises added no additional benefit. So really it was about the meditation and the state that was achieved during the meditation. And then in an emotional disclosure program, writing or talking about thoughts or upsets over the prior 4 days did tend to predict psoriasis severity and flares compared to a control group who just wrote factual statements about the preceding 4 days. So these activities, they can be helpful. They have demonstrated some data for use. If a patient, is agreeable to these things, then it's probably worth a try. And then acceptance and commitment therapy, which is known as ACT. This is very helpful for enhancing psychological flexibility. In psoriasis, it might be helpful for managing the unpredictability of flares, feelings of shame and grief. Oftentimes, what this involves is visualization or oral exercises where someone will, say a negative thought out loud, with a funny voice, or they'll sing it, and it actually then, by treating the thought in kind of this silly, jovial way, it minimizes the significance of the thought. And so this can be helpful for people as well. And these are, there are many ACT exercises out there, and many of them can be adapted to be done in office. So moving really then to the topic of interdisciplinary care strategies. So this is a tough one, and it really comes down to identifying what is realistic in your practice setting, assessing for the feasibility of screening, assessing for a comfort level of treating and screening, I would argue. There have been a number of setups where a psychologist or a psychiatrist is embedded into a practice setting, and this tends to be a very successful setup. We see this also in the world of pain medicine too. Looking at multidisciplinary case conferences, again, that also is setting dependent. Do you know a psychiatrist? Do you know a psychologist who would be able to do these things? And then also, I think, having a set of trusted community referrals is probably going to be in your best interest if you're treating patients with psoriasis, so that you have someone that you can refer to when you have a patient that you just, sense is having an issue with depression. And that's it. So questions, you can contact me here, or find me also too on social media, and that is my Instagram handle.